왜 코딩 되고 있는데? 소리가 안 나와. 되고 있네. 그 마이크 스피커 됐어, 맞나요?
홍 교수님 안 오셨어요?
온라인으로 줘. 완전 신나게.
I would appreciate it if you had
Okay, first take a look, and we will see the interpretation by one. So we would start with the left side.
Okay.
Yeah. you. This way.
Tachycardia, regular tachycardia, heartbeat around about 200, and growth first complex, LBB pattern, and inferior axis deviation. And also, I can directly say it is 15. It could be maybe sinus tachycardia with epilepsy, because delay tree I can see the P wave. Maybe it could be sinus tachycardia. Yeah. Yes, I think so. Sinus tachycardia with epilepsy. Yes.
Yeah, you must choose one.
Sinus tachycardia.
Huh?
Sinus tachycardia.
Sinus
Yes,
Sinus
tachycardia.
Okay.
Because I can see the P wave.
Okay, Seong.
Okay, I think the lead one and AVF is both positive. That means the axis is similar to normal, and the rate is about 150. But the QRS width is widened, and in the precordial lead, for example, in lead one, the RS complex is, I think, there is more than about starting from the R to the peak of the S, that is about more than 100. And also, I mean, in Brugada criteria for VT, and in the AVR read, the from the start of the QRS to the peak of the Q is about more than 40 milliseconds, and also I think the initiation is later, slower than the termination. So as the barricade criteria of VT, I guess those things prefers the VT rather than SVT. And if it is VT, then the X is normal and the V1 is negative. So I think this VT is coming from the left side of ventricle, and maybe the posterior basal origin of VT. So sorry, the V3 and V4, they are all negative. So maybe mid basal, I guess.
Okay, then based on the morphology criteria, you think that this is VT, right?
Yeah.
Great. Maybe it could be.
Yeah.
CT.
What do you think of the if you see in the bottom lead, you see that there is a subtly changing P waves. In the bottom, yeah, left. This timing is subtly changing, right?
Yeah.
And this, I don't know whether this is a P wave or this timing relative to the QRS is a little bit changing. And this as well, if you see this peak. So what do you think of that? Can that be a double tachycardia potentially going on?
Yeah.
If you think that the white QRS is VT, can that be double tachycardia?
I think the first one you said the notch in the after the lowest peak.
Yeah.
That
It-
could be the dissociated supplementary tachycardia, but I'm always not sure about those interpretations because it could be, but I cannot definitely tell that could be an evidence.
Okay. And do you think that this is a P wave? Because if you see, this is absolutely different from other notchings. What do you think of that? You think that's a P wave?
If it is a P wave, then the QRS, the PR interval is too short.
Okay.
And we cannot with in the same timing when we see the lead 3 and combined with lead 2, the suggested P wave is that in the lead 2, there. Yeah, so it looks like the end of the T wave rather than the independent P wave.
Okay. Yeah. Jim,
I think
but you're late, so
I think that the where the QRS ends and the P wave depression is there the morphology is different, and I think there is the likely P wave. This part, it may be a short VA tachycardia. This because this is different. This is different. I believe the likely P wave is here somewhere, just after QRS.
okay. So what do you think? This is a VT or SVT? Or you can do later because you're late. So Kofi can do it first.
So I agree with what has been said about it being a broad complex regular tachycardia. With the issue of the P versus T wave, when you look at lead 3 here, we see that there's a bump in here, there's a bump here, but the timing varies. And so the shape of this area also varies. Even over here, you don't really see the bump here like that, but I see this. And the distance from this to that is different from this to that. And that's how it progresses. If you look at AVR as well, you see those bumps up there and they are occurring at different times. So I think the A and the V are definitely dissociated. But the QRS morphology looks like a very typical LBB kind morphology, with the RS and then the upslurring ST, and then the same here. So because it looks typical, I'm thinking it could be an AT with aberrant conduction. Maybe there's a baseline LBBB, because I think there are at least 2 P waves in here, at a rate of about 300, an APR rate of about 300 thereabouts. Looking at these bumps, this is about 300. Yeah.
Yeah. So you're suggesting that AT is going on,
Possibly.
and there is 2-to-1 conduction.
Yes.
2-to-1 AT. You're suggesting, right?
Yes.
Okay. There is another opinion. So, 최민정.
You want the mouse?
Oh, that's okay. Oh, yes. The result we did the copy. First, the rate is about 150, and the axis is normal and typical LBB picture. And I thought this forms of P wave, so maybe the atrial tachycardia is ongoing and there is the aberrancy conductions going on. So I thought the SPT aberrancy and RC there is underlying AT component.
Okay, I think the intrinsic deflection is very fast. The initial VI. Let's look at V1, the downward slope, and 3, P4. This is very fast. Likely going through the HPS initially. Likely an SVT.
Yeah, as Wasim suggested, intrinsic coil deflection time seems not broad. But there is no answer to this. So this might be VT, even though some people suggest it's SVT. So Wasim, you're suggesting that this is SVT, right?
Maybe, but it can also be a very, near the septal RVOT really. That can,
Okay.
because 2-3 AVF is positive and transition is near V5. So, but seeing at the intrinsic coil deflection, I would keep SVT with aberrancy first rather than.
Well, I think that as Kofi and Wasim suggested, Chaemin-jung suggested, that the intrinsic coil deflection time is not that broad, which suggests septal activation. And the axis is normal and the AVR is negative, which suggests that in night, and also the morphology is not very typical, but close to LBBB. And we see the P waves in a 2-to-1 pattern. So at first I thought this was a 2-to-1 AT with aberrant conduction or fixed bundle branch block. But I'm curious of the true answer. So is Professor Huang there?
Yes, can you hear me? Can you guys hear me?
We can hear you.
Okay, good. So you have basically
Speaker.
why the complex tachycardia.
He's talking.
And
We cannot hear you.
can you? I have my speaker all the way up. Let's see. Can you hear me or no? No?
Maybe we disconnect and reconnect. Yeah.
I can hear you. You cannot hear me?
We can hear you.
Okay. You can hear me, right?
Yes.
Okay. So you have a lap on the branch block pattern tachycardia because you focus confused. There is a slight dissociation pattern on the 2, 3, and also in AVR, all that. But clearly, one complex QRS has two atrial activity going on. So what do we call this? Atrial tachycardia flutter. This atrial flutter, right? When you have a tachycardia rate close to 300, you don't call atrial tachycardia. It's called atrial flutter. So it would be a typical flutter. And there's an atypical flutter, which can go even faster, right? Now, if it is a typical flutter, which one would be most common? Type 1, which is a counterclockwise going on, and less commonly would be clockwise flutter. Imagine that you have a counterclockwise flutter. What would be 2,3 AVF? Would be negative, right? So someone earlier pointed out lead 3, there, Kofi, I think, point out that just before the QRS complex, there is this kind of a dip that he lead 3. So he thought to change a little bit, right? But then second, that would be second, flutter wave. Just before that one would be which one? End of a QRS complex, that slurred up stroke. Yeah, that one. But time to time, that timing is a little bit different because of, I think it has to do with probably AV nodal conduction going on. It's a variation here. But most likely still maintain 2-to-1 conduction pattern, regardless, whether slight linking break, but overall maintaining 2-to-1 tachycardia. So, and then also somebody discussed about the left bundle branch block aberrancy pattern here, which makes sense. But QRS V5, V4, V6 looks bizarre because of terminally influenced by the flutter wave, I think. That's why they changed that unusual shape. So I think a differential diagnosis you already made. Could it be a VT? Yes. What kind of VT can be this? If you have, for example, bundle branch reentrant VT, if a patient have a left bundle, you're going to have a bundle branch VT with the two different tachycardia going on, flutter and the bundle branch VT. Sometimes you cannot differentiate with this 12-lead ECG, but sometimes you can see bundle branch VT with the retrograde P conduction. Something looks like this, possible, but not 2-to-1 though, okay? So differential diagnosis would be just a straightforward VT, very unlikely. That's less probable. I think at top of the list still would be HF flutter 2-to-1 conduction with a left bundle aberrancy. But if a patient has the underlying left bundle, you cannot exclude the possibility of bundle branch reentrant VT going on with the retroconduction. But based on looking at the QRS morphology, QRS duration, as you guys have discussed, intrinsic activation time, all that is most likely HF flutter with the aberrant left bundle branch block. That's probably the most probable diagnosis here. Anything else we can tell? Why is the your flutter wave slightly trying to dislink from the QRS conduction? Anybody has the answer for that? If you look at the AVR, for example, very typical, you can see very end of a QRS, that's notching. You see that, keep following that. That's very just visible. And the second one into the yes, half of that would be, you divide that in half, would be right at the beginning of the QRS complex, right? You divide those guys in half, yes, your caliber. And so I think there is maybe a little bit of a summation going on, but different degree. That which will make you confused in lead 2. Take a look at the lead 2. Lead 2, end of a QRS now. You see that? Small spike, 2 of them. Yeah, and next one in the right before the QRS. You can see, yeah. So I think in a little bit of a different degree of a conduction aberrancy and summation going on. So I wonder, this left bundle branch block, probably the functional block. That's another indication from this, okay? Not a anatomical block. Anatomical block would not change, but a functional block can change this conduction, slight conduction change. So that's favorable also for the bundle branch reentrant VT. So this patient probably does not have a left bundle based on what I see. Okay? Anything else you want to discuss anybody has a different idea. More idea, better we are, okay? Keep giving us a new idea so we can discuss it. Anybody else in the audience?
Why did you think that this is a aberrant bundle branch block rather than a fixed?
The reason is that if you look at the QRS duration,
Yeah.
they varied by the EO floater wavefront. Okay, so some of them can be slightly narrower than other. That means you have a different type of lap bundle, right? Complete lap bundle, slightly less wide, and so on.
Okay.
Yeah, so different degree of aberrancy going on here. Okay, remember, bundle branch block is what? Aberrancy. What mechanism of aberrancy do you have? How many mechanisms of aberrancy do you have? Do you know? One is the long, short, long, typical Ashman phenomenon, right? That's one. Second mechanism, acceleration mechanism. Third mechanism, deceleration. Last one is the transsubtle activation concealed conduction of right bundle called bundle branch block. So there's 4 different mechanisms. Most commonly we see right bundle branch block aberrancy because in Ashman you will see because the right bundle has a longer ERP, refractory period, right? That's if you lung. But a left bundle can develop also in acceleration as well as deceleration. That's why. Make sense? So this tachycardia, probably 2 to 1, but I think functional block going on because of rate variation a little bit. So that's another thing that favor for the functional block rather than permanent left bundle. Okay? One day I think we need to go over this bundle aberrancy mechanism business. That's a very much a fundamental concept. I suggest you to read Charles Fishy book. You guys have it. I think Dr. Park gave you. There's one of the mechanism of aberrancy you should learn. There's 4 different mechanisms. Okay?
Okay.
All right. So read the Charles Fish aberrancy chapter of aberrancy. That would be a good time to read it so you can understand what I'm talking.
Okay.
Okay. Next slide. Let's go. So let's see what you do.
So she went to the ER, and ER doctor thought it was 3T, and she kept asking about chest pain, and her vital was a little bit unstable. So they performed the cardioversion, and after that, right after the cardioversion, the EKG was looked like this.
Okay. No, hang on a second there. After the cardioversion, what do you see? Is there any change in that segment that worries you?
There are ST segment depressions in the inferior and lateral leads, but it's possible it may be due to the tachycardia and cardioversion as opposed to true ischemic changes. So,
and how do you know that? Decide that. Patient could have a triple vessel disease, triple vessel coronary disease, right?
yes.
So what is against here? AVR. Look at the AVR. What does AVR looks like?
It's elevated.
Elevated, but a T wave is the same axis as QRS, right?
Yes.
Yes. It's an important point. You need to look at it. Okay. Because when you have a dispersion of refractory AVR, when it has an opposite direction of a QRS complex axis, then you need to worry. Okay. That's the bad news. Triple vessel main disease or something going on, but this patient does not. I'm just asking this question because you need to look for. Okay? Anything else? Patient has? The P wave you cannot see very well, but it looks like a P wave looks like a left atrial enlargement kind of pattern, but it's hard to know. Okay. Anything else? Probably that's it. All right. The next slide shows what?
Now the patient's information.
Mm-hmm.
The 47-year-old female,
Mm-hmm.
previously healthy, but the positive ER, obviously, because of palpitations and chest pain.
Mm-hmm.
Her chest radiograph shows no remarkable finding. And
Okay.
then she went to the EKs like she showed EKs like this. So she got admission to our department. Her lab shows no remarkable findings, especially the electrolytes was all normal and her cardio markers were all normal. And we run some tests to
Okay.
in order to rule out structural disease and coronary artery disease,
Mhm.
but it seems normal in normal range. And we are still running on tests like Holter's, MRIs, and TMT tests, and she got dismissed. Uh, After she will come back to return to the clinic at June 10th.
Now,
Although
can I ask you this question? When you guys look at the patient in emergency room, why so many testing? Is that any of this is justified? On somebody who 43 years old present with atrial flutter first time, she did not come with a significant cardiac distress, any other issues, would you do all this workup or not? That's
Oh,
a teaching standpoint.
this workup was when she
Yeah,
got after admission,
right.
cardiology department run this test.
I know, but the coronary CT, all that, is that really indeed necessary? Especially you're gonna do, all this echo and all that stuff already done it. So I think that is a management issue. If you examine the patient carefully and then you listen to the patient history, there's nothing really going on. I wonder whether it's coronary CT, angio, MRI, all this is necessary. Treadmill tests, probably I would have done that, but they're not in the Holter, none of those stuff. Because of concern would be first risk assessment issue, I guess. But then I'm not sure I would do the coronary CT and the cardiac MRI. She is a 43-year-old female, you said, right? Is a lady. Am I correct?
Yes.
What is the concern about getting CT? She get tons of radiation from cardiac CT, right? So why would you put someone unnecessarily exposed to the radiation, things like that? So I think all this testing we order automatically many times as a routine batch of a testing we do. You need to think about very carefully, examine the patient carefully, listen to the patient history, sometimes tell you more than anything else. Okay? I think when you don't find a good answer from first physical examination and the initial EKG and maybe simple echo, you need to go back to history again. There's something going on we are missing. Okay? Something she's not telling you or whatever. Then you don't need this cardiac CT or MRI business. Okay? We need the family history, we need all that before we order something to all this. Okay? Just for the teaching standpoint of view. I think that's why we're making medicine too expensive these days because they order everything in a one time. Boom. No, that does not work. Especially coffee in Africa. You wouldn't do that, right?
No.
Yeah. So I think we all need to be conscious about this cost of care. All right? Okay, let's go.
The day after admission, her EKG showed
Sure. Normalize. Okay.
life, and then she discharged with the beta blocker, and she probably we are considering EP study, but I'm looking forward to the test result. Thank you for your attention.
Okay. Thank you.
Good morning, Dr. Huang. It's me.
Good morning, Hang. How are you?
I'm good. Thank you so much. May I ask you one question, please?
Yes, please.
How can you explain the ST segment change after cardioversions?
Okay. Maybe other people answer this question. What's the mechanism of S segment changes after cardioversion?
Well,
Oh.
so cardioversion involves DC electrical energy,
Right.
and as a result of that, it causes some myocardial damage, and that results in repolarization abnormalities, which manifest as ST segment changes. And if you are to do a troponin right after, shortly after that, you will have a troponin rise, which is due to the myocardial cellular damage. But as it recovers, everything normalizes.
That's one thought. What other thought? So have you guys heard about the concept of electron poisoning? let's say that there's a patient who is a cardiac arrest, okay? You keep giving a 200 joule external shock and 360, keep shocking, and patient keep going to the VF. And then you stop shock, patient suddenly converted back to normal rhythm. Because this is a real case that we see. Electric poisoning means when you deliver in a concept of defibrillation, it has to do with concept of defibrillation. We have three mechanisms. One is the critical mass dependent energy issue. Second is the upper limit of vulnerability theory. Third is a complete annihilation of all wavefront by high energy shock. Okay? I don't know which one you believe. I don't think anyone knows for sure what it is. There's a three hypotheses. If you keep giving shock to the cardiac tissue, and then high energy tended to maintain long period of cardiac electron poisoning because the membrane potential was high, and then all the repollution abnormalities change. And in top of that, Kofi talked about the myocardial damage. So in combined two together, ion channels behave completely different. And at one point, you cannot defibrillate no matter how much energy shock you give. Best thing is that let the electron restore the electric activity, and then they stop defibrillating. Okay. So I think a lot of time we are too much in a hurry to do shock. No, that's why we need the shock. Then what you guys do? CPR, cardiac resuscitation. You keep pumping the blood, circulate the blood, get the acidosis better, and all that get better. Second potential mechanism that the patient would increase the heart rate suddenly, atrial flutter 2-to-1 for a long period of time. That itself also causes some S-segment depression, some changes in the repolarization. Okay, so those things are combined together probably. So maybe, Hang, you need to take a look at the mechanism of defibrillation. How's that? That would be very interesting to study. One particular author I recommend you to read is Dr. Raymond Eidecker, his name. Dr. Eidecker is trained at the Duke University. He's a world-leading defibrillation mechanism guy. He moved to the University of Alabama, worked with Neil Kay. So look at the Raymond Eidecker. If you don't find the article, let me know. I'll send you, okay?
Okay, thank you.
Great. Any other question?
No.
So, how long does it take for the myocardium to recover? I mean, the ST chain return to normal?
That all depends on how quickly you restore your circulation. That is the answer. Most effective thing is that you need to reverse metabolic acidosis, local tissue acidosis, and all they resolve quicker. If you don't, they stay longer time. In other words, patient blood pressure, hemodynamic circulation, all that restore, they usually wash out very quickly, and the repolarization mechanism restore quickly. Okay?
Okay.
Yeah.
Thank
So
you.
goal is improve circulation. Okay? That's what you guys learn in ACLS anyway, right? Okay. I think we 4-minute overtime. Let's go to the lecture.
So I will start today's EGM conference. The patient was 41-year-old female. She had a palpitation. It started about 10 years ago. It happened about 3 times per year. It showed sudden onset and sudden onset pattern and lasts about 5 hours. She doesn't have any medical history or family history of syncope or sudden cardiac death. So this was her 12 lead ECG for the tachycardia. It was a narrow QRS tachycardia with rate of about 150. And this is the ECG taken when she was not in tachycardia. And she showed the normal echocardiography and TMT. And this is for chest PA. She doesn't show any cardiomegaly or pulmonary edema. And we did the electrophysiological study. And this was her catheter replacement, CS in the lower RA and coronary sinus, and quadripolar catheter for HIS and RV. And during the catheter placement, the tachycardia was suddenly started, and it also showed the narrow QRS tachycardia, and it suddenly stopped it during the catheter placement. And when we started the exam, the cycle length was about 798, and AH interval 63, HV was 50, QRS which is about 95. And when the ventricular pacing on 600 milliseconds, the oldest atrial activation showed in the CS12, which shows the eccentric pattern. And the VA block cycle length was 320. And there was no VA decremental property during the single V extra stimulation test. And in the single V extra stimulation test in 600, 280, the VA conduction was blocked, and VERP was 600 and 220. And we moved to the atrial pacing, and the AVRT was inducted. During the A pacing, the signal goes up to from the CS, and the tachycardia was induced. And it also showed the rate about 150 and narrow QRS tachycardia, which was similar to the outside ECG. And the when you see the tachycardia cycle length was 421, AH was 245, HV was 46, and QRS duration was 95, which was similar to her normal sinus rhythm. And during the tachycardia induction, in the HIS refractory V pacing, the tachycardia showed the V reset about 80 millisecond advance, and PPIT still showed about 142 because the post pacing interval was 586, and the cycle length was 444, and tachycardia was terminated by the pacing the CS12. And when the atrial pacing was lowered to the 320, the AV block cycle length, AV block was noted, and there was AH jump and tachycardia induction during the single A extra stimulus test. You can see the AH interval was 208 to the 350, and also it started to induce the narrow QRS tachycardia. So in summary, the oldest atrial activation during the V pacing was CS12, eccentric pattern, and there was no VA decremental property. And narrow QRS tachycardia was induced by rapid atrial pacing and the single atrial extra stimulus test, and there was a V reset. And although the V intermittent pacing showed the PPAT there of 142, but it also showed the CS12 pacing terminated tachycardia. So we conclude that it is a left lateral accessory pathway inducing the orthodromic AVRT, and the dual AV node pathway is also present. So we replaced the ablation catheter near the CS12 through the septal puncture, and we under the V pacing, we try to find the accessory pathway signal, and after the ablation, the A1 V was dissociated less than in 3 seconds. And under the V pacing, the VA dissociation was noted, and still there was a AH jump. due to the dual node physiology. And we waited for 15 more minutes. And under the rapid V pacing, we showed the VA dissociation. And so this is the final EGM after the ablation. And this is the end of my presentation. Thank you.
Anybody, any question, comment, please?
Thank you for the presentation. I think from the beginning, the eccentric atrial activation, sort of suggested the presence of a left lateral accessory pathway, and the V reset being positive again supports the AVRT. The PPI TCL though was longer than expected, but I think that is likely because we were doing RV pacing, and so it's because it was RV pacing, the RV catheter was far from the circuit. I guess if we had tried LV pacing, perhaps we would have got a much shorter PPI TCL, either by putting the RV catheter in the RVOT or putting it in one of the posterolateral coronary veins, as we do for a CRT lead. But I think those are my comments. Thank you.
Yeah, that's also a good point. I also thought the PPI TCL was longer than 150, but we did the RV pacing, and we thought that it was high likely to be the left heart accessory pathway, so we didn't actually perform the LV pacing.
I have one comment. This is a very good case and likely very evident that poverty was a mechanism, but from an academic point of view, can it be just AVNRT with a bystander left lateral atrial activation? Because all we showed was a V reset in favor of AVRT, and the V got pulled in. That only proves the presence of the pathway. That does not prove the participation of the pathway in the tachycardia. What would have proven a participation in the pathway was termination by hissing PVC or delay of the atrial activation by not pulling in. So that's my only comment.
Well, so for in response to that, I think if I remember correctly, the tachycardia was terminated by a CS12 ectopic like pacing, and especially since CS12 was where we thought the accessory pathway was, pacing there would send the signal into the excitable gap to crash with the wave front that is coming, and therefore that would terminate it. So I think the fact that it's terminated with CS12 pacing supports the AVRT in the sense that it was able to go and then terminate the advancing wave front and then stop the tachycardia. So I think this, in addition to the V reset, would argue for AVRT as opposed to just a bystander accessory pathway.
So if you look at the tracing that you're showing right now, you deliver S2 from the CS12, okay?
Yeah.
Just before the His bundle depolarization. Can you see it? Look at the His channel. You see pacing spike and His bundle potential, right? Agree? So,
Yes.
so and that terminate tachycardia. That means you basically made the tachycardia circuit absolute refractory period. That's why subsequent bit coming around could not conduct anymore. It blocked. That's why tachycardia terminated, right? She made the pathway refractory, the terminal tachycardia. So that proves that this pathway is the tachycardia participant. Okay, let's go to the your first EKG first. So interesting that I don't know whether you guys are not going to be able to run this or not. If you look carefully, lead 2, what's the P wave looks like? That's slightly biphasic. You see that compared to the lead 3 or AVF, matter of fact. The initial portion is slightly taller. Can you see it? Right, that's initial positive. P wave right after QRS complex. Yes, come to the third, fourth, fifth complex. Yeah, right there. There's some small notching upward, which is less pronounced than 2, 3 in AVF. Okay. So that is one of the suggestions that often we look for. Sometime you guys are gonna ask me that question eventually. When you have a participant in Liga Marshall tachycardia, you see this distinctive P wave morphology, biphasic P wave in lead 2. Okay, let's go to the tracing. You're tracing now. So look at enough. Look, hang on a second there. Go back there. X-ray. It's okay. So where do you think that your catheter, CS catheter placed? Your EP catheter. Show the catheter, please. Yeah. Did you able to advance this catheter any further than there? Or just stuck in there, wouldn't go anywhere? Or you just left it purposely? That's my first question for you. Did you guys try to put it further out to the CS or not? Probably you won't go. The reason that your CS is pointing straight instead of going on. This is the area where you have a Bisson valve that blocks catheter insertion, especially duodecal catheter. Where the Bisson valve is where the Liga Marshall is. Okay? And then go to the intracardiac signal now, please. Now, you tried to put a catheter in and patient kept going to the tachycardia, right?
Yeah.
That favor for what? AVRT or AVNRT? When you guys trying to put a catheter in, patient keep going to the tachycardia. What favor? Especially chest catheter. AVRT. LVNRT seldom into the tachycardia by CS placement. Okay? Because you're touching distal insertion of pathway and then you're inducing tachycardia. Okay? So your atrial EGM, coronary sinus is what? Predominantly A. There's no V almost. Do you see it? Your CS EGM. Far field V. CS1, 2. Take a look. Whole thing is A. There's no V almost. Right? And then you have a quite separation between CS A and V there. Okay? All right. And then I want you to notice something for me. CS34, there's a small sharp potential on the far field V. Do you see it? Okay? Let's follow that guy now. Okay. Tachycardia, what happened? What do you see? Oh, go to tachycardia. In this tachycardia. Yeah, this EGM right there. No, just before that first one. Yeah, keep going. Yeah, that was one too. Okay. Yeah, that one. What do you see? B pacing. What do you see? Where's that sharp potential? Now in CS. 1, 2. 1, 2. Yeah. Keep going. Yeah, that guy right there. Did you notice that sharp potential? You did not, right? And then that's a positive. And 3, 4 is negative. It's A. I'm talking A. Okay? Right? That's QS negative. So your impulse breaking through, close the 1, 2, positive, and they have that sharp potential. Okay, keep that in mind. But when you stop pacing, next sinus beat, look at the last screen, sinus beat. That sharp potential came back in 3, 4. Okay? Just keep that in mind. Okay, keep going. And then during the tachycardia, let's go. Induced tachycardia. Okay, there we go. Where's the sharp potential now? That's a pacing, right? Then induced tachycardia. Now in CS, 1, 2 still, right? But it's negative now, not positive. So what's the difference? Why are you pacing ventricle is positive and during the tachycardia is negative? You need to think about this, right?
Yeah, I do.
Why the polarity change? And they become more negative during the tachycardia. So RV pacing, you're pacing from the septum, okay? The eucatheter septum. So then wavefront coming across the septal transeptally, and then going to probably come to the posterior, invading this coronary sinus area. How about during the tachycardia? It's coming down to the his bundle, going through what? Left bundle, right? Which conducts much faster than your RV conduction. That changes your vector of that. What does that mean? And then also sinus impulse is earlier in 5-6, that sharp potential. Why is it so different? Why the timing changing? You have to remember that in sinus rhythm, your left atrial activation happened what? Back one bundle, left atrial septal bundle, right? Septal pulmonary bundle, and then septal bundle, septal atrial bundle, and then cut out to what? Ligament Marshall, going to the CS. Now reversed. And V-pacing, opposite. Worst, longest possible. And then tachycardia, between two. So, and also you notice that during the tachycardia, your VA timing is not super short here. Only see big A, right? Now, go to your fluoro as an ablation site. You guys did very well, but luckily, very good, I think. Show me the fluoro catheter placement. I'll want to point out something quickly for you. Right there. Look at the LA view. And then area view. How far you're from coronary sinus? Very far into the ventricle. Do you see it? Do you expect to see that deep? Usually you try to put around the coronary sinus. If you target the distal CS1, 2, you're a good 10 millimeter away. Correct? You're much ventricularized. So you get the ablation signal now. What do you see? That sharp potential is in the H12, okay? And ablation also has a small pump right just before. You see it? Ablation distal. Upstroke. No, to the left. Yeah, that guy. That guy goes to that sharp guy, H12. And then your VA timing is very close now. Ablation. Far field V, just before. Yeah, right there. That's V. Okay? So this type of pathway usually insert around the ligament Marshall. You have two choices. One, ablate from the ventricular insertion, which Kofi commented earlier. You pace LV, find out where the ventricular insertion is, make your life easier before you start ablating. Or you have to ablate and higher up in the atrial insertion. Okay? I recommend usually ablate V insertion because it's much simpler, easier to find these potentials. Because we try to ablate in the past above the ligament Marshall is a much thicker tissue, much more complex ablation. So this is a reason why your patient tachycardia is left lateral, slow. They're not fast. This is a characteristic of tachycardia, by the way. So when you have a left-sided pathway around the Visan valve, tachycardia is very slow, easily inducible because of large excitable gap. Think about ligament Marshall involving pathway. Okay? In those cases, thumb is go to the left ventricle pace, look at the weight the ventricle insertion is, then target that area. Okay? You did very well. Wonderful. One burn. It's not that easy to do one burn this type of case. But remember that floor, how far away from the annulus you're thinking it is. Okay? Usually about 10 millimeter, 15 millimeter sometime. Okay? Otherwise, somebody keep chasing this all day, burning all over the place. It's because of very thick tissue. Okay? As you come up to the annulus, it's going to be much thicker. So you don't want to do that. Anybody has any other comment?
Dr. Huang,
Yes, sir.
when you do left-sided accessory pathways and you should paste the LV,
Yes,
do you like
everybody, no exception.
yeah, but do you put your quadri catheter in the CS and paste LV
No.
or just
We do
how
ablation.
is the
We do ablation.
Yeah.
You're gonna do transeptal anyway, right?
Mm,
So once you've done transeptal,
yeah.
area view, you're gonna rotate your sheath and catheter counterclockwise, perpendicular to the CS, parallel to the his bundle. If you look at this picture right now in the right side one in area view, your ablation electrode spacing is kind of an oblique view. His bundle is also not quite bad, but you see the septal his quadri electrode equally spaced, a beautiful example of the his septal. You have to rotate the ablation at the same angle as that the septal catheter, counterclockwise. Then you can just push down and then with the LV. Open the cut curve, just paste from the ablation catheter. Then look at the CS activation sequence. How much it change? What is the V, pathway, and A sequences? Simple as that. We don't need to put any extra catheter. No. It take extra 30 seconds to do that. Okay? The reason we are telling all this because left side pathway, usually V insertion is more proximal, septal. And then atrial insertion is more lateral, higher. So it's oblique fibers. So that's why we need to pace anterior to the pathway, LV, activate first, and then pathway, and then A. If you pace the right side, it's going to be A, V, all going to merge together because they're parallel, impulse. Make sense? So basically changing a direction of impulse propagation, you're trying to show that. Remember, I just commented about the sharp potential? If you do LV pacing, they're going to be opposite. Much nicer looking potential. You're going to see V, sharp potential, much wider space, and A, because they're turning around. V activate first before activate the pathway. IV pacing, pathway, V activate at the same time. They merge together because of your impulse going along together. Make sense? What I told you?
Yeah.
Okay.
I have another question. If you pace with ablation, you cannot map. So
What do you mean? You don't need a map. You don't need another mapping. You got CS catheter already,
okay.
right? So what I commented earlier is that what? You could not put a CS catheter any further in, right? This is the time you adjust your CS catheter. We like to see pathway bracketed by electrode number 3, 4, earliest, 1, 2 later, 5, 6 later. That would be better mapping use of a CS catheter. If necessary, this type of pathway, you may want to put another CS catheter inside because that would make your life a lot easier than you're just trying to hustle with the one catheter that cannot be advanced any further. Many times when things get complicated, also CS angiogram is very helpful. Okay? So you know exactly where a catheter is. Those things are important. So understanding anatomy first, and then proper placement, catheter position, and then you can do proper EP study. And that would make a procedure quicker, cleaner, less burn, also less complication. That has been our experience. Okay?
Thank you.
Thank you. Anybody else had any other comment, question, please? I can tell you, last month when I was in Korea, I ended up doing fourth time ablation left lateral pathway case. Exactly like a Marshall case. Very thick, deep tissue. And we tried to ablate all from the atrium. And then mistake. was. So we did the back end and map the ventricular insertion. We finished in 30 minutes. So everybody make a mistake, okay? Everybody does. So it's basically learning with experience. But I can translate you how to make your life easier based on from my troubleshooting and all this lifelong, problematic experience. So it's good to think about it and decide where you want to target. But left side pathway, V insertion of pathway would be better off than atrial insertion in general, rule of thumb. Would be simpler ablation, less burn, and then you can do well. Right side, no. Right side, the opposite. You want to target the atrial insertion, not the ventricular insertion in the tragus annulus, because the tragus is very wide, very long, very difficult to stabilize the catheter ventricular side. So those are different, or reverse. Okay.
Thank you. I have a comment.
Yes, please.
Yeah. So can you show the PPI minus TCL slide? So previously, two guys argued the long PPI minus TCL in this case. So actually, we sometimes does not catch the AH interval after re-entrament pacing. If you can see the AH interval is different during tachycardia and just after stop re-pacing. So in this case, patient have dual physiology. So we should correct the PPI minus TCL, consider this AH interval. It is we always check these findings.
So if you look at during the V pacing, look at your local activation time of the CS compared to during the tachycardia. If you look at for example, depending where you measure, but if you look at other than just pathway, 5 and 6, for example, 7 and 8, your local CS to the A activation time is much longer than during the B pacing than tachycardia. That's also added, wrong additional extra number. So question is that we always have to address is that what is the best thing to do at the post tachycardia pacing cycle lengths? I think best thing is to do, as Dr. Kim Min said, his bundle to his bundle, or local capture to the tachycardia, because when your pacing site occur, you don't know where the local capture is actually, okay? Because it saturates the whole signal. So I think somewhere a little bit proximal, maybe his bundle area, something like that, his V to the next B, something like that, may make also a little difference, okay? But I think one other mechanism why you have a difference is also, like someone already said it before, pacing site dependent, okay?
Yes.
Yeah, so all this, I think, interplay. So not single rule is absolute. So you have to put combine together and then think through, rationalize, and then which one is the most likely it is. But it's a good thing always, somebody mentioned about the bystander left side pathway, the AVNRT. Now, fundamental mechanism of that is what? If you do AVNRT, your CS pacing, S2, would not terminate tachycardia. Similarly, ventricular pacing would not terminate tachycardia because it's bystander. There's nothing got to do with the tachycardia circuit. And as you know, AVNRT can be independent of anything. So that's easy. I think a worse scenario is the reverse. You got AVNRT going on, and then there's AVNRT bystander. Actually, AVRT is active. Then it would be two different issues. Particularly when you have multiple pathway, you got two different pathway going on, and also patient has AVNRT. That can be really confusing. So I think key is that stay calm, do difference maneuver carefully one by one, then rule that out, or you can simply ablate one by one. You can all do that. So it's not anything magic about this. Okay.
Yes, so Professor Huang teach me very useful maneuver, the simultaneous AB, his refractory AB pacing can very helpful.
Okay.
Yeah, to distinguish these tachycardias. Thank you.
Any other question, please? Has been very interesting discussions and learned quite a bit. Okay, so I think you guys done well. Thank you so much for the conference.